Carla was my best friend at night when we would have an emergency heart and she would recover them. I knew that they were safe. So she's an excellent ICU nurse and she runs these codes all the time. I thank my volunteers for volunteering, especially Eddie Z for jumping in to be our anesthesia care provider, and he's got Alex helping me. Alex is a red hat there for you. So I'm going to have, let's see, Rachel, primary circulator. I'm going to, do you want Bailey's your secondary circulator? Do you want her to be with anesthesia right now, helping like intubate, or do you want to be over by the computer? Okay, so go by the computer. Tracy, I'm going to have you walk back by your back table because they're still like setting up. And my first assist, yeah, down. Okay. All right.
So this whole scenario occurs prior to induction of anesthesia? This is, we just got in a room, we just put a monitors on?
Yep.
Okay.
So this is a 55-year-old male who fell off scaffolding and broke his femur. Just brought in here, getting repaired, but perfectly stable, really no history. The best part of a mock code is to pretend like it's a real code. Who's ever got a red hat on here is a participant in the code itself. Everybody else is going to be an observer, and if you're observing, I want you to pay attention to compressions. Are they doing them effectively? Too fast, too slow? Because we're going to talk about that in the debriefing. It's a chaos, but it should be a controlled chaos in the room. Okay? We have a leader. We generally have at least 2 compressors, somebody running the airway doing respiratory therapy. We have a recorder head.
We have RT in here? Do we have RT in here? They're supposed to come back. We want to get them a hat on. No? Okay.
And then the important person, I don't know, I forgot who was supposed to be in this person, but the crash cart, I have a simulator on here. Unfortunately, it won't work unless it's plugged in. So crash cart obviously isn't always in the room, but we're going to pretend we're bringing it in. We've got defibrillator pads, go on the patient. Gets hooked up to this. It's already going to be on. We got the charge button and a defibrillator button. If the patient's in a shockable rhythm, meaning VTAC or VFib, we're going to shock. And I actually want to do it because I'm going to take this cord and put this on because this will absorb the shock, but we're going to actually charge and press the button to defibrillate when need be, if need be. Okay? So biggest part is I want to see what everybody does. I want to see how it goes. The best part of a mock code is the debriefing at the end. So everybody who's watching, everybody who's doing, pay attention to how things are going, and we'll talk about what went really well, what went well, and then maybe some opportunities for improvement. Okay, any questions?
Yes. Is this intubatable mannequin?
Yes. He is an intubatable mannequin.
I feel like you're going to need some lubricant.
Usually this story, right?
All right? So again, the most important part is don't ask questions. This is a patient, you wouldn't be asking a lot of questions like, don't look at me, I'm not even here. Like, do I do this, do I do that? You just do, and we'll talk about it afterwards. Okay?
I don't think this is intubatable mannequin.
We'll just bag him then.
It doesn't have a mouth opening other than the hole. All right, so the scenario based on the normal scenario. Has anybody ever been in the code in the OR? The code in the OR usually is completely different from the code on the floor, correct?
Correct.
It's much, normally, should be, any code should be less chaotic, always less chaotic. In the good code, there's no chaos. Should be a nice and quiet room with people executing commands of one person. Everybody is delegated to do their job, and the key to any emergency situation is to be prepared. Therefore, I always say 6 P's. Proper preparation prevents piss poor performance. In any code, take your own heart rate first, relax, and focus on the task that you've been designated. So we in the room, everybody has scenario in front of them. this person came in, we're putting monitors on, and all of a sudden we have sudden change. Doesn't mean that everybody needs to start flopping around and screaming, somebody calls for help, everybody goes. So as anesthesia providers, here we're a team of anesthesia providers, we're gonna designate. So you are a circulator, I'm sorry, what's your name? Bailey. So Bailey, start applying pads, please, because we know that something is drastically changing, and we see the heart rate, the blood pressure is dropping precipitously. Right away in our head, we know that this person fell, there's a long bone fracture, most likely we're dealing with fat embolus, and that's what, based on the vital signs and everything, so we know probably what's going on. So we're gonna take care of the airway as you putting pads on, which will give us two things. Will give us continued ECG and also will give us ability to shock, because we expect it.
Nothing's happening yet.
Yeah, so just put the pads on, Alex, take care of
Oh, wait a
the
minute.
airway. So airway's in. What?
Yeah, we're gonna go ahead and
We're gonna,
read.
we're gonna say start, and then we're gonna recognize the rhythm, and then we're gonna go from there.
Okay.
Are you ready?
We are. So we have monitors on, we're applying oxygen as well.
Monitor is here currently.
Right, but what I'm saying is that, and then all of a sudden you look at this. So we're gonna take care of the airway. We have a shockable rhythm. Let's put pads on. Please call for help. We need crash cart in the room. I'm going to pull out epinephrine to be prepared for the next steps while Alex is securing airway. We have a code situation. We need pads on, airway secured, please.
So you're gonna call for help?
Crash cart is already in the room.
No,
Fabulous.
you're gonna call for the crash part, so kind of let it play out.
Okay.
Let it play out. Go blue button, go, start up.
Oh, look, the pulse ox is 96.
Oh, actually.
It's reading room air, 96. Pretty
Okay,
good.
so I'm coming in with the crash cart,
Okay.
and I brought some people with me. I'm like, hey, what's going on? What do we have here?
We have a patient that deteriorated suddenly. We have a shockable rhythm. We need to have pads on, and we need to administer 200 joules, please.
Okay,
Somebody needs to start CPR.
all right,
We need a compressor to start CPR. We have
I need a
secured,
documenter.
we have secured airway.
Okay, so I'm gonna have you document.
The patient is right now, the patient is on a ventilator. You don't need to synchronize with breathing. Ventilator is working, you can do CPR. We need a first amp of epinephrine please to go in. Are the shocking pads ready? Are we ready to shock? Charge please to 200.
Charging to what? 200?
200 joules
200
please.
to pay charging.
Let us know when it's ready please. Continue CPR.
Rachel, have you called the unit to find out if we can get a critical care bed, or do you want me to do that?
Alright, I'm charging.
Sure. Okay,
Can
I'll
we
call.
do that first? Epi in please.
Yeah, we. All
Epi
clear.
on, all clear.
Shock.
Shock. Continue CPR please. Epi in, first shock.
Okay, so you're not touching meds. Your crash cart person's gonna give you the meds. Yep, it's gonna give you the meds and you give them.
Charge to 300 please.
Okay.
How you doing, Tracy?
300.
Do you need to change out on this one?
Sure.
Okay, Dr. Bone, I need you to step in.
Alright,
We are ready,
clear.
all clear.
Clear. Charge.
I will start you.
All right, good. Continue CPR please. We have a V.
So my assistant, I want you up here to be with anesthesia. You can ask,
How many minutes has it been since the first Epi?
A minute and a half.
Okay.
you can ask him, do you want another anesthesia care provider? You can ask if you want art line.
Yeah, if somebody wants to start working on Heartline and another access please.
What I mean by that.
So go
Well,
down to
we'll
your
drill a full
cart,
lot.
try to get stuff out.
ABG, we need whole lights.
Yeah, we're gonna hit your meds, mix up meds.
All right, let's charge again, and let's defibrillate again.
Okay, and you want to charge it 300?
300.
Okay, charging.
There's no outline stuff, you'll have to call anesthesia or run to get them.
Ready?
Everybody
All
clear?
right, everybody clear.
Pushing the button.
All right, the patient continues to be in non-viable rhythm. Continue CPR, please. Do we need to switch or compressor?
Yes, who's next in the line?
Let's give it next. Abby,
Nope, nope. Nope.
Abby, one number, Abby.
All right, let's deliver it and flush
It's
it.
been 2.5 minutes for
You gotta move away from his
Huh?
Do you
still.
want to wait for 3 minutes for the epi?
No,
Okay.
Okay,
we'll just give it another epi.
flash.
How about calcium? Do we have calcium in the
We
room?
have bicarb, we have.
Let's give both calcium and bicarb, and let's continue CPR and do flushes.
Okay, there will be,
Okay. All right, let's charge again.
Okay, charging at 300.
It's a biphasic, 360.
You can still do it.
Okay. 360.
Yep.
All right, charging.
All clear?
All right, clear. Hit the button.
Okay. Still have the same non-viable rhythm. We're continuous. We need somebody else to continue CPR.
CPR.
Who's next in the rotation?
Need another compressor.
Okay.
So you all have to
Continue
stay.
CPR. Patient is on 100%.
Actually, they hadn't made incision.
Just, please.
Okay.
So we're gonna continue with the CPR. We're gonna charge the 360 again, please.
Okay, charging at 360.
Withdraw all the labs, right? We sent all the labs already? Okay.
All right, clear.
All clear, please. Let's
Pushing the button.
Hold on 1 second. We're not continuing CPR. We're gonna assess for pulses. Do I have pulses?
Here's the pulse.
Okay. Do I have our line already?
There.
What's our line saying? Do we have viable blood pressure anywhere other than carotid?
Blood pressure 70.
Okay, so we're gonna deal with it here. We're gonna start using some kind of pressors depending on what we're dealing with. We're gonna continue 100% oxygen. We're not gonna make an incision. We're never made an incision, correct?
Correct.
Yeah, we're just gonna go to the ICU or cath lab, one of the two, maybe spiral CT, there's a P somewhere. But at this point, we're gonna maintain the pressure, we're gonna deal with 100% oxygen, and we're gonna diagnose the problem and deal with the problem before we deal with the femur. Is that
Okay. All right, we'll conclude it at this point. We're gonna watch it right away, Sheila, right?